Good morning and welcome to this webinar on difficult weaning of cardiopulmonary bypass. My name is Gianluca Paternoster. I'm from Italy. My topic is inotropes and the weaning of cardiopulmonary bypass. I have no conflict of interest. Before moving into the topic, it's good that we remember how the inotropes works and what are the main adrenergic, dopaminergic, and vasopressin receptors and where they are located, if they are located in the vascular district or in the cardiac district. This is crucial because when we decide to use one inotrope or another one, we have to know very well where they work. Is also important to know that alpha receptors are in the vasculature, and the main effect is vasoconstriction with the increase in cardiac contractility. The beta-1 receptors are located in the heart and they increase heart rate, cardiac contractility and cardiac output. And the beta-2 receptors are located in the vasculature and they cause vasodilation and the bronchodilation. It's also important to know where they are located, if in the right ventricle, like in this picture, or in the left ventricle, because we have to choose the right inotrope for the right ventricle. And here is clear where alpha receptors are located and where beta receptors are located. A crucial element when we wean patient from the cardiopulmonary bypass is to select an appropriate therapeutic regime with the aim to not increase heart rate and to not increase myocardial oxygen consumption. A difficult weaning from cardiopulmonary bypass was perfectly highlighted by Jean-François Hardy in 1993 with the association of a relatively high filling pressure and low systolic blood pressure. Please keep in mind this definition: high filling pressure and low systolic blood pressure. If we need to use vasoactive drugs, or if we need to go back to cardiopulmonary bypass again, or if we need mechanical assistance, this is the difficult separation from CPB. And in this situation, we have to start to think to use inotropes or vasopressor. The common factors that are related to or vasopressors use for the weaning from cardiopulmonary bypass are female sex, older age, low ejection fraction, cardiac enlargement, long duration of CBP, long duration of ischemic time, and the ACE inhibitors used before surgery. But if we are in present of a difficult separation from CBP or complex separation from CBP, there is an increasing in mortality of our patients. So we need to be very well aware to this situation. The inotropes effects are to enhance post-ischemic recovery, but also to promote, for example, insulin resistance, or to increase myocardial oxygen. That is what we need to avoid. So when we start to use an inotrope, we can have a transient hemodynamic improvement, but we can have late adverse effects, and this is important. So when we start to think to use an inotrope, we need to, before moving to switch on the pump with the inotrope, we have to consider that our patient is underfilled. So it's important to check with the transesophageal echocardiography or with the right ventricular inspection and optimize preload first. This is the first step. If normal ventricular function with the normalized cardiac output and map, then we can start to think to use an inotrope. So be aware to optimize preload feed first. But also in normal volemic condition, there is a difficult weaning from CBP in a percentage from 10 to 45%. The second step is to see with echocardiography if there is intracardiac shunt, if there is valvular regurgitation or leaks, or there are occluded bypass graft. We call these structural abnormalities, and this is something that the surgeon can do to wean the patient from cardiopulmonary bypass from this difficult situation. But our aim, our principal feeling is to see if there are dynamic abnormalities, if there is a left ventricular dysfunction, if there is a right ventricular dysfunction, if there is a vasoplegic syndrome, or if there is a diastolic dysfunction. So if there is a low cardiac output, we need to define it very well. Low cardiac output is the inability to wean patient from cardiopulmonary bypass despite a maximal support with the low cardiac index, less than 2.0, 2.5 liters. And or if there is the evidence of organ dysfunction, for example, urine output less than 0.5 milliliters per kilo per hour. We have to be aware to imbalance between oxygen demand and delivery in this situation, because we may amplify the myocardial reperfusion injury. And we have to be aware that the increasing level of catecholamines in this situation is associated, for example, with bacterial growth, with increasing germ virulence and biofilm formation. What is the evidence that support or not support use of inotropes? We have the 30-day mortality increase in patients that receiving inotropes, British Journal of Anesthesia, the high troponin levels in patients that receiving inotropes, anesthesiology, the increased mortality and renal dysfunction in patients receiving inotropes, critical care, and there is no association from William between inotropes and adverse effect in high-risk CABG patient in Journal of Cardiac Surgery. This is the evidence that support or not support the use of inotropes today. Is important that we need to assess with the transesophageal echocardiography the cardiac output measurement, because this is the key point to define low cardiac output syndrome. But we have also to be aware that there is a hemodynamic response to incremental dose of inotropes for 5-10 minutes. And about these two highlights, there is no consensus today. What is the optimal therapeutic regimen? The optimal therapeutic regimen. So how to do it? How to choose the right inotrope in low cardiac output syndrome? We have to be aware that patients with low cardiac output syndrome are tolerant to beta adrenergic agonists. So we need to start to think to the adjunct of non-catecholamines agents when the incremental dose of beta adrenergic agonist fails to announce ventricular contractility. And these agents are levosimendan, milrinone, and enoximab that augment the efficiency of cardiac contraction, that increase the stroke volume, that has less metabolic cost than catecholamines. The PD3 and the PD5 inhibitors, as you know. Milrinone enhance coronary blood flow, improve right ventricular function, improve diastolic function, attenuate the biomarkers release, and has a few myocardial infarcts. The levosimendan, for example, has a better hemodynamic profile, reduce mortality, reduce ACI, reduce myocardial infarction, reduce atrial fibrillation. And the The second difficult situation to wean patients from CPB is vasoplegia. Vasoplegia is defined as low systemic vascular resistance with hypotension in presence of normal or increased cardiac output. So again, we need to measure the cardiac output and we need to measure the systemic vascular resistances. Has an incidence from 5 to 45%, is limited in severity and duration, but has an increased mortality and morbidity, is, as you well know, similar to sepsis-induced vasodilatory shock. To better understand the therapies, we need to remember just 1 second what are the main receptors that are involved in the vasoplegia. They are the V1 and V2 receptors, and their agonism increases systemic vascular resistance and increased blood volume, with the results of increased arterial pressure. The treatments that today we have are adrenergic vasopressor, norepinephrine, but today vasopressin and argipressin in particular are very useful in the treatment of this syndrome. Vasopressin has an increasing evidence because has less side effects, argipressin in particular, reduce atrial fibrillation, reduce acute renal failure that sometimes is related with vasoplegic syndrome without increasing the pulmonary hypertension, as you can see in this slide. Increase cardiac output. The blue one are patients receiving vasopressin, and the green one is the control group. Increase the mean arterial pressure without increasing the central venous pressure significantly compared with non-receiving vasopressors patients. The last situation that we need to check and we need to be aware is the diastolic dysfunction. Diastolic dysfunction can occur immediately after weaning off cardiopulmonary bypass, can require inotropes and vasopressor, and if it's present before cardiopulmonary bypass, increase the risk, for example, of vasopressors use. Diastolic dysfunction is a predictor of inotrope support. So is the earliest marker of myocardial ischemia. It can reflect the clinical functional status of our patient. Is a very well studied in the setting of aortic valve replaced after aortic stenosis. Diastolic dysfunction is affected, for example, by a long cross-clamp period or a long cardiopulmonary bypass. And what is the right inotrope or vasopressor in this setting? This is the flow chart that can help us. So in the immediately post aortic valve replacing patient with diastolic dysfunction, we have to be aware to fluid administration because sometimes it's related to pulmonary edema. We have to be aware with the inotropes because they can increase the pulmonary hypertension or the shift left to right ventricle. Maybe we have to start to think to use vasopressors in the difficult weaning from cardiopulmonary bypass in this situation. So just to conclude my presentation, I will share with you these recommendations for use of positive inotropes that is published by CBP subcom of EACTA and in conjunction with the others important society. This is a recommendation that is under a big discussion. That is a good thing, and I hope that moving from this slide we can have a constructive talk. So in conclusion, when we are in presence of difficult weaning from CBP, we want to use an inotrope or a vasopressor. Please consider underfilling as first step. Then do the right diagnosis or the left or right ventricular dysfunction, and remember where are located the receptors and how the inotropes works with the alpha, with the beta, with V1, with B2, with PD3, with PD4. Don't forget Vasoplegia, and start to think argypressing, vasopressin in this setting. Don't forget diastolic dysfunction, in particular in a patient after aortic valve replacement. If there is low cardiac, if there is in this situation, if there is a low arterial pressure, please start to think to use vasopressors. That's all, and thank you very much for your attention.